Good morning, everyone. I'm trying to start punctually because we have a pretty packed program. We have 3 speakers and a complicated topic. So welcome and thank you for being here. Before we get started, first of all, I want to just tell you Elaine isn't here right now, obviously. I can't do her job very well, but she is en route from California, and she will be here, I think, arriving tonight. I want to also remind people that we are collecting the $8 for breakfast at the door. Janet's taking care of that, and there's also an attendance sheet floating around here someplace. Just started. I want to ask people if there are any public announcements that need to be made. I know that there's one in particular that I'm interested in people hearing from Sabrina, and I think there was another issue. We're going to have Jeff do his tidbits as well, and I think that's pretty much it for the start of our program. I did want to say that we have 3 panelists here today, and Larry will give you their bios and introduce them. One from government, and one from business, and one from academia. So that should cover all the problem areas in healthcare, other than the fact that when you need healthcare, which is your biggest problem. So in the meantime, I'm going to ask for public announcements. I'll pass the mic over to Sabrina first. Is there any other group here that needs to make a... Okay, so we have Malcolm and we have Sabrina, and then we'll hand this over to Jeff for his tidbits. Hold on a second.
Good morning. I'm Sabrina Fiddleman, and I'm a member of the Summit Board, and I'm also on the Town of Mamaroneck Town Board. And I'm the liaison to the Town of Mamaroneck Housing Authority, and they have asked that we make the following announcement. As most of you know, I think they are responsible for the Hommocks Park Apartments, and there is a vacancy in the Hommocks Park Apartments now. It's a 1-bedroom with loft, and it'll be available approximately on the 20th of November. Priority in living in those apartments is given to volunteers in the fire and ambulance departments, local government employees, school district employees, and residents of the area, although non-residents and non-employees may also apply. If anybody is interested or knows anybody who is interested, please give them the following information. The property is managed by Gramerton Management, and their telephone number is 914-654-1414. In addition, if you'd like to be placed on their waiting list for an apartment in the future, you can call that number, and they will do that for you as well. Thanks.
Good morning. I'm Malcolm Froman. I'm a member of the Summit Board, and I'm switching hats now and speaking to you as the president of the Larchmont Mamaroneck Hunger Task Force. As many of you know, we're the beneficiaries of lots of food drives during the year from local organizations, temples, schools, classes, Boy Scout and Girl Scout troops. But once a year, the food pantry holds its one and only food drive, and that's going to be this weekend. It's called our pre-Thanksgiving food drive, and if you're shopping at either Stop and Shop right over here or into Chico's, you're going to be greeted by our volunteers who are going to be handing you a flyer asking you to, while you're shopping, to buy an item, one of the items listed on the flyer, to contribute to the food pantry. So when you're out shopping, please think of us. Thanks so much.
I nearly forgot to remind people that the Community Resource Center is having its annual gala on December 6th. It's their big fundraiser, and we would love to have you attend. I'm on the board of the Community Resource Center. If you can't attend and you're in the mood, we would love to see contributions. This is the big fundraiser for them, so it's usually a wonderful night and a lot of fun, and you're all welcome, and we hope you'll consider coming. Thank you. And now I'm going to turn this over to Larry. Oh, no, Jeff. I told you this is not my normal job.
Good morning, everybody. So today's program is on health, and I thought I would do a tidbit on health. Rarely do I segue, but I hope to. So I got to thinking about how did we treat health years ago? Because we have a big transition. So in the last half of the 1800s and the early part of the 1900s, who provided health? It was all private, in the sense that government didn't provide health. And it was provided by an enormous number of volunteer societies, groups, mostly church-related. So I happened to go on the Brooklyn Daily Eagle Almanac of 1918, and if you Google that, you will find thousands of societies and so on listed. The City Mission and Tract Society, the Edwina Free Kindergarten, the Sitic Brooklyn Tree Society, who entertained 4,500 children and gave coal and clothing to poor families. So, and a lot of them were church-related. We still have some vestiges of that. For example, the Presbyterian hospitals. We got two, the Columbia in New York. The Archdiocese, the Catholic Archdiocese, which today still provides nursing homes, Mary Manning Walsh, Arch Care, which is their health program, the old Flower Fifth Avenue Hospital that I remember my parents talking about the old Flower Fifth Avenue. Is now the Terrence Cardinal Cook Health Center. So what about Mamaroneck? What did we do here at that time? Well, I'll give you three examples. There are probably many more. First of all, the Sisterhood of the Hebrew Institute in the early 1900s formed a group, a society, mostly ladies, and they did hospital drives, Red Cross, and the Hebrew Institute, they were centered at Halsted Avenue, where Dance Kavis is. That was the first synagogue, now on Palmer Avenue in Rockland. I remember I looked at a couple of the names during the time, and I remember it says Morton Ed Margolius. I don't know if you all remember years ago, but there used to be a very high-quality men's clothing store in Mamaroneck on Mamaroneck Avenue, Margolis Clothing Store. So that was one example. The second example was the country division of the Manhattan Midnight Mission of St. Michael's, which was started in 1883. And this was a refuge for fallen women, a home for wayward girls. Does anybody know where this was located? Oh, you haven't been listening to my tidbits. No, it's Leon. Thank you, Leon. A trustee. He's done his homework. Yes. He's out on the lookout for him. Well, actually, it is. It's the Village Hall at 169 Mount Pleasant Avenue, and that was the home. And it used to have a wall around it, a fence. And my father grew up on Prospect Avenue, a couple of blocks from there. And one night he came home to his very stern Methodist grandfather, or his father, my grandfather, I never knew him, and said, "Father, what is a wayward girl?" There was probably, frumping around. But the kids used to try to peek over the fence to see the wayward girls. And that became, eventually that petered out, and in 1939, that transitioned into the Mamaroneck Village Hall. Now, the most important one, my last, is the Mamaroneck Health Center. And this was a consolidation of two organizations at the time, the Child Welfare Association and the Mamaroneck Society for Lending Comforts to the Sick. I love these titles. And a lot of the old names were there. Mrs. Charles Baxter, the Baxter family. Charles Baxter started the library. His son became a judge. Mrs. R.P. Brewer. You've heard of the hardware store. And I'm happy to say my grandmother was on that. She was the secretary of the organization. Well, they became the Mamaroneck Health Center. And what did they do? Tell you what they did. This is from 1946. Today, the health center provides prenatal care of mothers and has established an orthopedic clinic and dental clinic and is the milk station for the community. Nurses are available for the care of the sick in the home, as well as education and health supervision. Clinics and classes are conducted regularly. Pediatric and social hygiene clinics are conducted weekly, chest clinics twice monthly, orthopedic clinics quarterly, and special immunization semi-annually. During World War II, the health center was organized as the main casualty center for Mamaroneck, was equipped for all emergencies, et cetera, et cetera. So they did a hell of a lot. And it was run by local folks in the community. Sadly, they sort of petered out. They tried to hold on, and in the late, actually all the way up into the 70s, when they really felt they couldn't support each other. And by the way, it was located in the building at 234 Stanley Avenue, where the Community Counseling Center is now located. And that was the child welfare building, and when the two organizations combined, they used that building for all of those years. So in the late 70s, they decided to dissolve, and they had to petition a court to dissolve. And I have a deed dated August 18th, 1981, where the Mamaroneck Health Center, as successor to those two organizations, was deeded to the village of Mamaroneck. And two of my favorite people since passed away. One of them signed this deed, Mary Montesano, who was the wife of a very good friend of mine, Busy Montesano. She died of breast cancer. And the other one was Norma LaRosa. And some of you will remember Norma LaRosa and Herb LaRosa from Rhinebeck. In any event, what a lot of people don't realize, and Leon as a trustee, I hope village trustees recognize this. In consideration of the sum of $1, lawful money, and in further consideration of the agreement of the party of the second part, the village, to use the property hereby conveyed for its health-related activities, as more fully stated in an agreement filed in court. So that building, to be used by the village, and I remember at one point one of the mayors said, gee, we need that for electrical thing, workers and so on. And I pointed out to them, you can't. So that's why we have the counseling center there. And it's also why in the basement, the Washingtonville Housing Alliance had its first office. Both of them, if you twist it a little bit, are health related. And that's my tidbit. Thank you. Oh, yes, my board member on LMC-TV. Monday nights at Sedona. Have steak. It helps support LMC-TV. Thank you. Yeah. $6 steaks. Janet, you've been there.
I'm going to pass this over to Larry Thal now so that he can introduce the panelists and we can get started on their presentation. Thank you.
Hi, everybody. Can you hear me? Is the Verizon commercial? All right. That's okay. Well, I just learned, as I do every time, more about the town I've lived in for 28 years. That was wonderful. Thank you. So I want to thank you all for coming, from elected officials present to neighborhood business owners to our membership, regulars, my friends, and my friends on the panel. I totally appreciate the board getting behind our committee, that's Rose, John, and John, to have this presentation on such a vital topic to us all. I'm Larry Thal, and I was recently named to the board. I'm a healthcare insurance broker for nearly 35 years, working with businesses, organizations, and individuals. I've lived here in the town, I just said, for nearly 28 years, and I feel compelled to share my resources with you today. It's open enrollment season, after all, right, for healthcare, and these are professionals I've come to know over time, some more recently, who have a lot to share from different vantage points. Thank yous go to County Executive Latimer's office for his recommendations as well. And it's really the education and the conversation which are the most important thing. Healthcare constitutes nearly 20% of the entire U.S. economy. I would repeat it, but we've got to keep moving. That said, I think you'd agree it consumes at least that percentage of our attention through the media every day, advertising, and our general conversation. It's that important and very expensive to us all. Every day we see articles. Healthcare for less. Doesn't matter what newspaper it is, right? It's all over the media. Okay. So today, to the end of education and questions and answers, we've assembled an expert panel which, from various perspectives, will put together a snapshot for you of where we are now as far as our access to affordable, quality healthcare, and where we're headed, and how. Though not a presentation on the Affordable Care Act per se, it will help us understand where we've come since its enactment in 2010, as well as the effect of technology on our healthcare and on our health. Okay, we're going to do that. Certain terms will be defined for us as well as their effect. Terms such as single-payer healthcare, as appears in New York proposed legislation, or Medicare for all. We'd like to hear how these would affect us. I'm sure they'll be incorporated into the presentations. One factoid to share with you about Westchester County's healthcare ranking, according to the Robert Wood Johnson Healthcare Ratings, as reported by the Business Council of Westchester, our county rated 3rd out of 62 in general health in 2018. I have that literature if you want to see it later. Of course, I don't want to steal any thunder from our experts who have plenty of their own facts and statistics. A word on our focus today. As important as this topic is, literally, we're speaking about our health. This is not a political presentation, albeit just a short week after Election Day. Our focus, rather, is on what we can expect healthcare coverage and its delivery to evolve into in 2019 and beyond in our state and in our own locale. Also, it's nice to hear the history of healthcare in our locale dovetailed into this. Thank you, Joe. Other related topics such as drug addiction and mental health will be treated specifically in other meetings of the summit. Now, to introduce our experts. We're very fortunate not only to have true experts with us, but that they braved the weather to get here. We took pains to select an academic, a healthcare economist from New York Medical College, right here in Valhalla, an experienced insurance futurist who is the regional vice president for United Healthcare in the Northeast, 12 states, and our own regional director of the New York State Small Business Marketplace for the New York State of Health. Now, I'm going to do their bios a bit. I'm going to do that. So, our Professor Adam Block, is currently Assistant Professor of Public Health in the Division of Health Policy and Management at the School of Health Sciences and Practice at New York Medical College. He is a health economist with deep experience in the health plan, the hospital plans, and the government sectors. He has research interests in how individuals make decisions in healthcare markets, and his research activities focus on patient selection of hospitals, patient selection of insurance plans, and diffusion of innovation in the market, as well as evaluations of medical technology. So that's Dr. Block. He will speak first, but I'm going to continue the bios for a moment. Should I do the bios in a row? I'm going to do that. So Desmond Hussey, seated at the end, is the Regional Vice President of Marketing and Product Development for United Healthcare Northeast. He began his career at Oxford Health Plans in 1994 as a group sales representative in the New York City office. Since then, Mr. Hussey has held numerous posts in marketing and product development at Oxford and at United Healthcare, which acquired Oxford in 2004, you may recall. In his current role, he oversees new products and portfolio management in 12 states, plus the District of Columbia, who is responsible for implementing the product requirements of the Patient Protection and Affordable Care Act, ACA, across all business segments, and is actively engaged in interpreting regulations and developing effective product responses. Recent product launches include an ACO, a Accountable Care Organization product, focused networks products in New York, New Jersey, Connecticut, Pennsylvania, and the entire Mid-Atlantic, and something called Sweat Equity, a wellness product that rewards members for exercising. Okay. Mr. Hussey is responsible for all aspects of marketing in the Northeast states, including B2B campaigns for employer groups, product marketing support, development of sponsorship to drive broker engagement, and the use of digital and social media to build the brand. Can I have the bottom? Can't see. I wish I had 3 hands. Thank you, Sabrina, you're the best. Stana Nakle is regional director for she's our regional director in our region for the small business marketplace of the New York State of Health. That's our state healthcare exchange. Stana oversees the New York metropolitan region, working with small businesses and health insurance brokers as they navigate new health insurance options available through the New York State of Health. Ms. Nakle has a wide range of experience with government and private health insurance, having previously held the position of Director of Private Health Insurance Initiatives at the New York City Human Resources Administration's Office of Citywide Health Insurance Access, where she oversaw their efforts to promote affordable health insurance coverage for small business and working individuals. And I'm going to include born and raised in Slovakia, Ms. Nakle worked and traveled broadly before earning a Bachelor of Arts in Social Science from the University of Bridgeport and a Master of International Affairs from Columbia University. Okay, now I'm going to say something else. We're going to start now. Okay, so how it's going to work is that each panelist will speak. I'm going to ask an initial question that they'll incorporate into their answers. It's not a stumping question, but just to get it going. But at the end of each of their presentations, your questions. We'll invite your questions. I'll repeat them, and then they'll answer. So let's begin with Professor Block. I must add also, before we start, that he contributed significantly to the roster of minimum essential coverages as specified in the Affordable Care Act. There were 10, I recall, minimum essential coverages. So here's my question. It's a different question. Can we expect technology to help us change our awareness and our personal behaviors, resulting in measurably improved health outcomes? So technology, So I'm going to turn it over to you now. And if you can stand while you speak.
Sure. Yeah, so I think technology, of course, is really important. One thing, so I've been working in healthcare in 20 years, and one thing that I have been surprised by in technology in the last 20 years is that when the internet revolution came about, let's say in the early 2000s, we still saw physicians with paper records. We still saw physicians faxing things, right? What is a fax machine? Well, all of your physicians have them.
A little bit louder, please.
Sure. Here we go. I really do have to hold it close. Yeah. So what is a fax machine? I'm sure your physician knows, right? Hospitals still use beepers. And so what I'm seeing now is the uptake, and all of this, the important thing here is electronic medical records. And they did not really start being uptaken until very recently. But now you see most of the major hospital systems have Allscripts or Epic. And to be honest, I mean, I'm sure that anybody that works for Allscripts or Epic or any of Cerner, all the major companies, will say that there's an enormous difference between them. But what's important to us as consumers is that your organization has one. And while there is, have we seen a lot of hospital consolidation? Have you seen it? Right. Northwell has come from my home in Long Island to your home here in Westchester, right? Montefiore has moved north. We've seen a lot of hospital consolidation. And what I will tell you is two things. One thing is that, and in addition, they're taking over doctors' offices as well. So the good thing of that is that you can expect that a lot of those small doctors' offices will start to be forced, whether they like it or not, to incorporate technology, right? Electronic medical records. And why are electronic medical records good? Well, it means when you go from your PCP's office and your PCP takes an X-ray to your, pulmonologist's office, that pulmonologist will not only have access to your X-ray, but may have even seen it before you've come into the office, right? So that's why it's important. And In addition, one thing that the downside of all this market consolidation is that what does market consolidation lead to, right? I'm a health economist. What does it lead to? It's monopolies, right? And what I would say is that, so I go to all these health economics conferences, and what the purveyors of this would say is, no, it doesn't. We're reducing prices. No, that's not true. Like the health economic evidence says two things. One is that market consolidation leads to higher prices, period. And it leads to no change in quality. Because one theoretical thing could be that, well, we're improving quality, but no, I don't think there's not really great evidence that it improves quality. It's really that it increases prices and doesn't really change quality. I do want to talk about, I know Larry said that this was not going to be political, but I have the microphone. So I just want to tell you a little bit about my background. So more specifically, I went to Washington in 2008 and worked on the drafting of the Affordable Care Act. I worked for the Joint Committee on Taxation, which is very similar to the Congressional Budget Office. And so I was in back rooms where they were helping draft the legislation. And then right after the Affordable Care Act passed, I moved over to the Department of Health and Human Services and drafted regulations on the essential health benefits, actuarial value, a whole bunch of other things, small business. I was actually one of the first people involved in the small business reforms. And what I really want to talk about is none of that. What I want to talk about is the midterm elections, because I want to tell you something that I saw having been a part of the Obama administration in 2010. And what happened in the midterm elections in 2010? Anybody remember? There was a Republican wave, right? The Republicans took over the House of Representatives. And the day after that happened, what I was told is, we have to be careful what we say on email. We're going to be investigated for a million different things, right? And that is exactly what is going to happen on the other side. And what those investigations did was it slowed down the pace of work. So whatever the pace of work that's happening based on the Republican administration on a regulatory side will be slowed down, because all of a sudden all of these people that were trying to crank out regulations, whether you like them or not, they will not be able to do as much of that regulation writing as they otherwise would have been able to had the House not gone into the, right? So what's going to happen is the Democrats are going to take over the House, and there's going to be a bunch of investigations into a lot of things. Now, some of those things will be White House related, but some of those things will be, what are we doing on the Affordable Care Act? And the investigations will go everywhere, and they will suck up a lot of, A, the media air, but B, some of the regulatory time. So I think what we're going to see is a slowdown in the change in regulation that is coming from Washington. And that is based on my experience having the opposite, working for a Democratic administration and having a Republican take over of the House. Now we have a Republican administration and a Democratic take over of the House. Okay. So let's move over to, do you want me to talk about single payer? Okay. So I went to a conference, I go to a conference every, single payer. Single payer means that basically that the government, it's essentially Medicare for all, where the government is the primary payer of healthcare, as opposed to now where we have a lot of different payers for healthcare, right? We have, just to break it down on a national scale, we have 170 million people in the private sector through employer-sponsored coverage. We have about 50 million people in Medicare. We have about 70 million people in Medicaid. And we have about 25 or 30 million people, does that sound right, in the individual market in the U.S.? It's not right, it's not that far off. And then we have a decent portion of the population that still remains uninsured, right? About 9% of the population is still uninsured. And single payer is something that is being considered, I've heard about it, talked about at the federal level. And what I'm going to tell you is that is not going to happen. I went to a conference last year in 2017, and I don't mean ever, but I just mean in my lifetime. I went to a conference called Academy Health in DC. They have it every year, and it had former CMS directors, former Congressional Budget Office directors, and a moderator went down the panel to all of these extraordinarily senior level people and said, what is the chance of, single payer, even if, administrations change? And basically they said, no, it's not going to happen. I'll tell you the only pathway where I could see it happening would be at the state level. One thing that we see happening here is that there are more and more what we call state waivers. And what a state waiver is a waiver that permits the state to basically take money that would have gone to the Affordable Care Act expansion and use it however they want. Now, I know that there are single payer proposals in New York State. New York State is a really big state. California is a really big state. Both geographically, it's politically diverse, even though I believe that the Democrats took over the state Senate for the first time in a long time, and Andrew Andrew Cuomo won by a substantial margin. It is really big, and so the place that I would expect this to happen to first, if it were to happen, would be a state like Vermont, right? Vermont is much more uniformly liberal. There's not that many people that you have to insure, and it has not been able to take off in a state like Vermont. And then I would expect it to happen in a state like either Maryland or Massachusetts or both. Remember, the Affordable Care Act started in Massachusetts. I was living in Massachusetts when it started. I was one of the first people that had to pay the individual well, I didn't have to pay the individual mandate penalty, but I was subject to the individual mandate. And so I would expect it to happen in places like that. So the tendency in American policy is for things to happen in the laboratories of democracy, the states first, and it would happen with a liberal state, probably in the Northeast like Vermont first, and then move to some of the more other smaller states like Massachusetts and Maryland before it came to a place like New York. That's just been my experience with single payer, and also with how progress sometimes happens when it comes to health policy. Yep. 4 minutes? Sure, absolutely. So I'd imagine that some of my colleagues will talk about this, but I pulled some numbers from the New York State Health Enrollment Report, and I'm just going to say some of these numbers to highlight that when we talk about the Affordable Care Act, there's two things that are happening, right? So I teach a health economics course, and I give my lecture on the Affordable Care Act, which is really the source of my experience tomorrow. And I talk about two things. One is that, the Affordable Care Act, it was not focused on reducing costs. As much as people who have a liberal tendency like to think that it was a be-all and end-all, it was focused on one thing, and it was expanding coverage, reducing the uninsured. And what it did was it reduced the uninsured from about 14% of the population to 9% of the population. All this hoopla over 5 percentage points, right? That's really what it did. And most of that reduction did not come from the exchanges. The exchanges, I love the exchanges. I helped write the regulations that created the exchanges. I think, they're markets that I think work very well. I think they're fascinating to study, and there are millions upon millions in them. However, to me, they are the show horse of the Affordable Care Act that shows that these markets can work, and they get a lot of the attention, all the pre-existing condition stuff. That's all the exchanges. However, the workhorse of the Affordable Care Act is the Medicaid expansion. The Medicaid expansion, Medicaid went up from 58 million people to 73 or 74 million people as a result of the Affordable Care Act. So most of the people that got insured by the Affordable Care Act went into Medicaid. And there are 4 million people in New York State in Medicaid. And just to give you some comparisons, I think there are, in Westchester County, there are Fidelis in 2018. Fidelis has a 49% share in the exchanges, and that's 7,360 people, right? There's 15,000 people in the exchanges in Westchester County. Now, some of the other counties are larger, but just to give you some sense, like the exchanges are not that big in Westchester, and they're not that big anywhere. There's a couple of 100,000 people in the exchanges, and so they are not the main driver of the expansion. One thing I will say is that what we've seen is, I don't want to call it market consolidation, because market consolidation would imply that companies are merging together. What we've seen, though, is there was a co-op in New York, the co-op, Health Republic, giant disaster, owes $1 billion and will be in the courts for years. Care Connect, I had Care Connect. I think I have my card with me. My wife works for Northwell, so I had Care Connect insurance. They went out of business. Affinity Health Plan based in the Bronx. They are consolidating, and by that I mean they exited the exchange market in maybe it was 2 years ago. So it went from having 10 plans in the New York area to having really only, I think, six plans competing, and Oscar. Have you guys heard of Oscar Health? If you've been on the subway, particularly in November when it's open enrollment season, you've seen Oscar everywhere. They've got cute little cartoons. It was started by Josh Kushner, Jared Kushner's brother. He's one of the founders of it. So Oscar actually is interesting because they are a startup. They're expanding everywhere. They've expanded into the small group market this year. They're in the small group market this year. And they expect to be in the Medicare Advantage market, I think they said in 2020. Have you heard that? Oh, okay. Oh, okay, excellent. So yeah, you'll be able to tell us, but I'm pretty sure, well, it's not 2019 because 2019 will be now, so I believe they're targeting 2020. So what I will tell you is based on Oscar's financial statements is, and you can confirm or deny this, even though it's true, they've lost a lot of money in the New York State market. Their financial statements to the New York State Department of Financial Services showed that they were actually losing money year on year. And 2018 has been the first quarter where they've actually seen some gains. Now, they are expanding nationwide and doing very well. So it's going to be interesting to see, based on that expansion, what happens with Oscar. Yes. Yeah. So let's ask some questions.
Okay, so now it's the question and answer part. I'm going to give you the microphone.
Yes, I recently had the opportunity to spend some time in a very highly rated hospital. I'm interested in your comment on technology. The one thing I noticed from earlier visits to hospital in my life is that most everybody walked around with a screen in their hand. I spent some amount of time going, hey, over here. I wonder if you could comment on the effect of that, because I was told I was not the only patient that had made that observation.
So this is a big concern, and so my wife is a physician at Northwell, and actually 5 or 6 years ago she made a study where she had medical students follow around residents and click the time on how long they spent with the patients versus looking at screens versus eating lunch versus, and what they found was that it was actually surprisingly short. It was only about 8 minutes a patient. So it's a big concern that some of the nature of the dynamic has changed, where physicians are looking at screens. Now, from a physician's perspective, some of the information that they get, right? Like, what is a physician's job? A physician's job is to diagnose a medical problem and treat it, right?
Yeah, because you're going to run out of time.
The information to diagnose that medical problem comes from two sources. One is you and your story, right? It's looking at you, examining you, speaking to you, hearing about your history. But another is the electronic medical records that I mentioned. They are looking at all of your past medical history. They are looking at the notes that your specialists have written. So it's not, one thing I would be careful of is don't think that they're checking like their fantasy football league. Like they are, I would be confident that they are checking things related to your medical history, even if they're not. In addition, simultaneous to that, they are also writing down notes about what's happening for the next, right? Because you have a continuum of care. They're writing down notes for the next piece.
So it's fair to say that they have to develop a screen-side manner. Screen-side.
Agreed.
So what we're, yeah. Yeah. So what we're going to do, there's so many good questions. We're going to hold the questions for the general QA answer period. We have to do that. One thing I learned is that the Affordable Care Act should have been called the Accessible Care Act because it was access to care. Am I correct? Would that be fair?
Well, should have is a political question, right? It was called the Affordable Care Act for a reason, even though that was not what it was doing.
So we'll talk about that later.
All right,
Next. Thank you so much, Doug, Professor. Now to Desmond Hussey from United Healthcare.
Okay, thanks.
Wait. I'm going to ask you a question because
you are?
you put out all these forms. So is it all really about laying out the cost of care? And here's a question for you. Do you believe that the industry has begun using artificial intelligence and big data and sophisticated machine learning so to eventually lead to algorithms to result in better, more predictable health?
Well, that's a mouthful, Larry, and the answer is yes. Is this on? Can you hear me? So the answer is yes. And in fact, companies like Optum, which is part of our United Health Group organization, has huge databases, and if you don't put those databases to use effectively, they're waste to maintain. So yes, the answer is yes, and I'll give you some examples about how that's going to go down. But first, I wanted to say thank you to Adam for confirming for me that there's not going to be single payer during his lifetime, because he looks a lot younger than me, so I figure I'm pretty good for the duration of mine. As a healthcare insurance executive, that's good news for me. So looking around here, you know, I realize there's not a lot of millennials among us here today. Okay, you know, we're that other group of people in the healthcare thing called patients. Okay, so we're the ones who are getting the care. But some of what I'm going to talk about really relates to how millennials and just younger people, or the people who are coming up, they do things differently than we do. They're not afraid of things that we're very afraid of, and that a lot of that has to do with data. And so we're really going to see change, and I'll give you sort of a couple of examples. So you were talking about the history of Mamaroneck and of medical care in general, and how it functioned differently back then. And I want you to think about it in a slightly different way. So today, if you wanted an appointment with a doctor, here's the sequence, right? Stop me if I'm wrong, but you get on the telephone and you dial a number and you call and somebody answers the other, and you probably have to press a couple of buttons. And then you speak to somebody, and that person then gives you an appointment. Probably not for that day, probably maybe the next day, maybe a couple of days ahead, sometimes weeks ahead. At the time that appointment is made, if you've got it in your calendar, you get in your car, you drive down there, you park. Sometimes parking is a problem. Then you go into a building. We can all picture this building. Every building we've been into, medical building, you go up the stairs, you open the door, and there's a big, long row of windows, okay? And behind those windows are nurses or folks who welcome you in the receptionist group. And sometimes, increasingly, they're actually giving us now an iPad, which we like. But lots of times, you still get the string and the pencil, and you fill stuff out. Then you go sit down, and then somebody comes out, mispronounces your name. You go in the back room. You're sat in an office. They take your blood pressure or something, then close the door and say the doctor will be with you shortly. And you sit there in a dark room until the doctor comes in, opens the door, and says, "So what seems to be the problem?" Now, here's why I bring all that up. That entire experience, every step of it, hasn't changed one bit since 1950 or even earlier. Okay, so in the infancy of television, that experience was precisely the same. No other business is anything like that, what it was in the 50s, and if it were, it would be out of business as an industry, okay? So as we think about innovation in healthcare, the upside is enormous, because what we're starting with is an experience that looks like 1950. It's just bypass. You said we were sort of late to the game a little bit in technology. Well, think about that, okay? So there's all kinds of opportunity. And the kinds of things you're thinking about is that millennials don't like any part of that. Any part of it. From picking up the phone to getting in a car, they don't do any of that stuff. So everything's going to start changing to different delivery systems. And right now, most millennials would rather go into a CVS to see a doctor than to go to some doctor who they're sort of attached to. Now, we can say whether that's good or bad public policy not to have sort of primary care doctor, but at certain stages of your life, probably is much more meaningful to that member. They get much more satisfaction by having that instantaneous, I need it now, I go to CVS, they're going to tell me something. So here's where the electronic medical record comes in. So when we think about this kind of innovation in technology, the comment was that electronic medical records go from PCP to pulmonologist. And it will, and that will be very important. But where I think it's even more important is that it goes from PCP to CVS. Okay, that other physicians who are going to be treating you, or not physicians, PAs, whoever it is, in telemedicine models, are going to have access to that electronic medical record. They're going to know what kind of meds you're on. They're going to know what your history is. That's critically important because then they can deliver a much more meaningful level of care if they've got that data in front of them. And by the way, in keeping those medical records, and those organizations, frankly, will be better equipped in some ways to maintain up-to-date electronic medical records than a doctor who might be, 60 years old and not really into that iPad that they've got. But that won't be the case for telemedicine, who will be under, strict orders to keep every record. Won't be the case for CVS, who will be under strict orders to keep every record. They will then capture that encounter with that patient, put it in the electronic medical record, and that will be available to the pulmonologist later on. So that transfer of data is going to happen in a lot of places that are not typical for us today. Telemedicine is something which is exploding. It's exploding in our United Healthcare plans. It's something that we're bringing to mental health. Telemedicine works really well for mental health. If you think about, having to drive to, park in front of the shrink's office, nobody likes to do it, and you won't have to. And the telemedicine is actually a really good way to have a consultation with a psychotherapist or any kind of a therapist. And we believe that'll be a growing level of care that people will do. So, yep. But that's exactly what they are. So it starts with video. However, what we're finding is, for a lot of people, they'd rather text. Younger people, you've seen your kids, whatever, your grandchildren, they're texting. They're not. So for them, we're actually finding that we've got to make text to nurse, text to doctor available. That's equally important. So the concierge PCP things that you hear about that are emerging, where the concierge says, pay me once, $1,600 a year, I'll give you all the care you need. And you know what one of their biggest selling points is? You text me anytime. Here's my mobile number. And that is one of the great things that people really like about that model. Okay, for PCPs, by the way, are having to create value, to deliver value, to say, this is why you need to see me, because I think in general, their importance with electronic medical records properly in place, the meaning of a PCP as the quarterback for care, used to be they had the file. That's right, what was behind those nurses, behind the glass windows were a bunch of files, paper files. And they alone had them, okay? But now, if everybody essentially has an electronic file cabinet on all the people, maybe the necessity of a PCP, certainly for younger people, healthier people, is less important. That frees up PCPs for the rest of us who need them, okay? So that the PCPs may well evolve into a more a disease-specific provider category where they take care of people with diabetes and so on. PCPs are primary care. So family doctor, okay? So the good old family doctor just is not necessarily going to have to take care of younger people anymore. They're going to be far more available to take care of people with chronic conditions and so on. So I'll pass along the mic. I just want to say a couple things about drugs, though. So the sheet that I handed out sort of has some examples of the types of things that are sort of below the waterline in terms of managing affordability. It's not just what you pay the doctors. It's how you manage the care. Drugs are going to be extremely, extremely important. They are developing in ways that nobody foresaw. There are single drugs that cost $1 million per person. Now, there's a drug now that cures a rare form of blindness. It's a genetic drug, gets injected into your eyeball. It's $500,000 an eye. It's specific to that person. But guess what? It actually changes the genetic code, and young kids can now see because of it. So it's this miraculous, truly miraculous. That's what the miracle was. He's blind, now I can see. And yet that is something that's happening today in healthcare. Very specific type of blindness. But the point is that that'll roll into bigger and bigger things. We talk about North Shore being out here. Well, guess who else is out here? Sloan Kettering, right? Because Sloan no longer is doing surgery. Sloan is doing medications. You go to New York, you get diagnosed in New York, they tell you what it is you need, but you get the medications. You don't want to schlep into New York. You want to stay out here, and you can get the medication infusions out here. So the point is that models are changing, data's behind all of it, you're going to need data partners. We like to think that our company is a terrific data partner. We have more medical data than anybody else, but it doesn't do any good unless we put it to use, and that's what we're doing in our plans. So I'll hand it over to Stana, but I think we'll take questions at the other end. Is that right, Larry?
Okay. Thank you so much, Des. You brought your energy. That's what we wanted. All right? So, Stana, so it's your turn. Please enlighten us as to the state of our New York State of Health, our healthcare exchange and its many programs, knowing your expertise to be in the small business marketplace as its regional director for our area. Now, here's my question for you. How is the New York State of Health doing in getting people who never had coverage covered for the first time by the right policy and keeping them covered?
Doing great is the short answer. No, I'm just kidding. Okay, so my name is Stana Nakli. I am the regional director of the Small Business Marketplace from New York State of Health, which is one of the programs that New York State of Health covers. But just to give you a little bit of a background, you may know this already, but I'm just going to recap. So basically, when Affordable Care Act passed, what it did is it allowed states to decide if they wanted to build their own health insurance exchange in marketplaces or not. I don't remember the exact number, but I believe it was either 12 or 19 states in the US had decided to build their own exchanges, and then the rest of the states said, we don't want to do that, we're just going to let the federal government run that for us. And of course, I don't know if you know this, but New York State is very progressive when it comes to health insurance, healthcare, and of course we decided we have to have our own exchange and run it ourselves. So that's what we did. We built a marketplace. It's called New York State of Health, and it's run by the New York State Department of Health, and that's who I work for, just kind of as a background. So the exchange, the marketplace, opened its gate in 2013, and so now we are starting our 6th open enrollment period. It started on November 1st, and the open enrollment period is going to run until the end of January of 2019. So again, New York being progressive, we actually have the open enrollment period twice as long as the federal government's open enrollment period is. So basically the thinking behind that is to allow enough time for everybody to be able to shop around and decide, what sort of type of coverage they need for their family and what they want to enroll in, make sure that they can really think it through and actually enroll in coverage. So the statistics that Dr. Blog was telling us about uninsurance. So basically, the Affordable Care Act had many goals, but one of the biggest goals of it was to decrease uninsurance amongst our population. And the statistics that Dr. Blog was giving us, saying that the uninsurance went down from 14 to 9%, that is nationwide. But in New York State is actually better, which I really feel like it's because we have a marketplace and exchange here, which does a lot to decrease that uninsurance. So since we started in 2013, we have enrolled 4.3 million people. That's through the end of the last open enrollment period, which was the last January. So that's 4.3 million people that got insurance through New York State of Health, which basically translates into the uninsurance rate in New York State decreasing from 10% to slightly below 5%. So we're really proud of that. That's one of the goals that we really are trying to accomplish, is decrease the uninsurance rates as much as possible, make sure that everybody has access to health insurance, that is able to get it and gets it. And then, we really want the uninsurance rate to be as low as possible. So the answer is yes, we're chipping away at, insuring people. Every year we insure more and more people. And even though the truth is, yes, most of the people that are enrolled through New York State of Health are enrolled in Medicaid programs. But still, we go out there and we find those people that are eligible for Medicaid and we get them enrolled in the program. Otherwise, they wouldn't have anything. Some of the people didn't realize they were eligible or just didn't want to get coverage for whatever reasons. But we go out there with very extensive marketing campaigns and people that we have out on the streets looking for people that don't have coverage and getting them insured if they can. So just kind of a little bit about New York State of Health. We have two different programs. One is called the individual marketplace, and the other one is the small business marketplace, for which I work. The individual side is for individuals and their families to access coverage. Also includes sole proprietors, which many people don't know. Sole proprietors are business owners. They are definitely businesses, but in terms of health insurance access, they actually get coverage as individuals. And then the other side of the marketplace is for small businesses specifically. It's much smaller. It offers some benefits to small businesses, which I will touch on in a minute. So basically, we want to make sure, the message of today for me is to make sure that you spread the word, because you represent the leadership of this community, to spread the word about, open enrollment is here. It started on November 1st. For those that never had coverage, people that did have coverage and are renewing their plans, they can come on November 16th in a few days and see what is out there for next year in terms of plans, choices, prices. Do they want to pick something different for next year, shop around, or just simply renew their coverage? And for small businesses, we have a small business marketplace that offers some distant advantages. Basically, there is something called small business tax credit. It's available to small businesses with less than 25 employees with certain wages that are actually offering coverage to their employees and paying for at least half of it. So if you know of small businesses that would fall into that category, and actually most businesses not only in New York but nationwide are really, really small percentage-wise. So there is a small business tax credit available. It's available for 2 years, and what it does is if you're eligible for it, you can actually get up to half of the premiums that you paid for your coverage for your employees back. For some businesses that can be a significant saving. I've seen statistics and it really can save a lot of money. And basically what happened this year was New York State of Health sort of opened the small business tax credit to anyone that's otherwise eligible for it. Previously, you would have to enroll through New York State of Health only to get the tax credit. Now we changed that, and as of April of this year, anyone that's eligible by the IRS rules and is for the tax credit can actually access it and take advantage of it. So the message for me is spread the word about the open enrollment for individuals that don't have coverage. Let everybody know. I know that this area does really well in terms of accessing coverage and actually having people insured, but you never know who might be out there not having coverage or know somebody else. And then if you know any small businesses that may be able to qualify for this small business tax credit, encourage them to come to New York State of Health and check it out. We have tons of tools on our website. You don't have to enroll in anything. You can just browse. That's one of the other things that we make it really easy. You come, you put your zip code in, and you will see all the plans available to you, how much they cost, what they cover in details, what provider networks they have, what doctors participate. You can kind of shop around, and that's available for both individual consumers as well as small businesses. We also have thousands and thousands of assisters that we trained to be able to provide assistance to people. Shopping for health insurance is complicated because it's very, sometimes you're not sure what the things mean, how to navigate it, how to really pick the product that's best for you, the plan that really best suits your needs and your family's needs. And that's why we have people that are professionals that are trained to be able to kind of guide you through this process, and they are free of charge. They're trained by us. They're in every single neighborhood of New York State, speaking many languages. All you do is just call up and see who. Actually, go online and you can put your zip code in and see who is available to you, or call our call center and ask them, how can I meet with someone so they can explain my options to you. And again, they're free of charge. So I really encourage people to take advantage of these people, because that's what they're there to do, to help you select the best coverage for you. Thank you.
Thank you, Stana. It's terrific. I just want to say that it took years, I believe, I'm at liberty to say this, for all the departments of government to talk to each other. So when you go onto the New York State of Health website and you put in your information, you've got Department of Taxation. You're going to make a representation of what your income was for the prior year to see if you might get a subsidy or some payments, and it's going to be checked automatically.
Just to add about the subsidy,
Go ahead.
I don't know if people know this, but there is a financial assistance available through New York State of Health to people that make up to 400% of federal poverty level, which in dollar amounts translates to about, family of four, it's about $100,000 and $400 this year. So any family of four making that kind of income, all the way up to that level, we provide financial assistance. So, of course, the less money you make, the more we pay towards your premiums. So, again, I encourage people just to look on our website, put your basic information in, and see what you may be eligible for.
That's really good. And one of the departments that does not tie in is the FBI, so it's just Department of Health. And okay. So now we're going to open it up to the questions and answers, and we have the first.
Since you work on the Affordable Care Act, most of us felt at the time, rather than trying to kill it, they should have tried to make it better. What were the things that should have been done that would have made it better?
Do you want me to say public option?
Tell me what you thought at the time.
Sure. So at the time, I think, there's one of the reasons that premiums, or are people aware that last year premiums went up a lot? They went up a lot because of something really weird, which is called cost-sharing reduction. Do you remember this? Right? And the Trump administration cut them off. And basically one of the things that I thought should have happened was that they should have just embedded the cost-sharing reductions, which are this separate stream of money that has to be done through basically appropriation from the House of Representatives. They should have done that directly through the tax credits. So that was one thing. A public option would have been interesting. The concern about a public option, and I think this is a rightful concern, is that how do you set the prices with the hospitals? What does Medicare do? Medicare just says, this is the price I'm going to pay you. Take it or leave it. That is tough. And I think it creates a more vibrant market when you have multiple options, meaning that, if you don't like the price that gets offered, maybe United is going to get a better price. And maybe Aetna is going to get a better price than that. And then maybe the hospital is going to come back to United and then give them a better, right? So you have this dynamic. So there is a concern about the public option that that this sort of dynamic market of negotiation with the private sector would have gone away. So that was one thing that I would have maybe liked to see.
Hi, everybody. I'm Susan Riley from the Mamaroneck Library. I just wanted to mention that we have free help for people to select their health plans. It's on Saturdays at the library, and it is available in Spanish as well. Thank you.
Hello, thank you very much for your presentation. My name is Elizabeth Rosenthal. I'm a retired physician. I've lived in Mamaroneck for 44 years, and I'm a very active member in Physicians for a National Health Program. So I sort of feel like Daniel in the lion's den here, because you all have only presented one viewpoint. I noticed that the title of this was Post-Reform. Well, some of us don't think we are post-reform because we think that the real reform hasn't happened yet. And I do not agree with you that single-payer Medicare for all is not going to happen in your lifetime. Maybe not in my lifetime, but I think it will happen in your lifetime because it's what we have now, where the private health industry takes 30% off the top of healthcare spending, we can't afford, and it's breaking our economy, and it will. So the question is, how can you sanction? Doesn't anybody see that the market, a free market, is not appropriate for health care? Does that not occur to anybody?
Admittedly, I'm a free market person, so what I would say is that much of the healthcare delivery system is not in the free market now. Medicaid, Medicare. So the people that are, in the most need or the most deserving of coverage, they have government-sponsored coverage. So there's a great deal of that going around. The question we have to ask ourselves is, are we willing to cut healthcare by roughly a half to go to a public system? If we were to spend the same amount of our GDP as Sweden and Norway and those places, you get half the healthcare you get, because they only spend 10 to 12% of their GDP on healthcare. We spend, as Larry said, close to 20. So to some degree, that's going to have to happen. Well, the GDP expenditure on healthcare in national health coverage countries is much, much higher than ours. That's what we always say. We're spending too much of our GDP on healthcare. That's right. We are. But the question is, I beg your pardon. So I think that's part of the discussion. There's an element to coverage in this country which is not perfect. We all know it's not perfect. Companies, like ours, public entities, research environments are all trying to find out a way to make healthcare more affordable for people. Some of the bigger issues, though, that I don't think have been accounted for adequately are, for example, drugs. These enormously expensive drugs. The government is going to have to make decisions. Is that person worth $1 million? Is that person worth $500,000? Is that person worth $200,000? Or they can say, no, everybody can get whatever they want. Or they can also say, well, as you said, we'll price those drugs for the drug companies. One way or another, you're moving into an area that just, from a political standpoint, in this country, I don't think everyone's ready for the way it would take place in the country. But you're right, it is a different kind of situation. Healthcare is different, and it needs to be dealt with differently. And I think that us as taxpayers and the country as a whole has done a good job at creating access to care for the poor and for the elderly.
One last question, one more assemblyman.
So thank you for the great discussion, and thank you, Larry. The question I have was sort of touched upon a little by all of your comments, which is the dynamic of how do the economics, whether it's a current system or a public system, work if healthy people, maybe millennials, but other kinds of healthy people, have the choice of not getting any insurance until they get sick. And that seems to be the macroeconomic challenge of whatever system you want to pull together. So your comments on that, I think we as a country are going to have to confront that in a way, because even before the Affordable Care Act, we had community rating, we had all sorts of kinds of mechanisms to deal with spreading the risk and spreading the cost appropriately. So thank you, and thank you for the good discussion.
So I'll start off on that. Thank you for that. That's a great question, and I probably should have brought it up earlier. I think, Assemblyman, what you're referring to is the fact that in the 2017 Tax Act, that the only thing that touched on healthcare was to remove the individual mandate. And what the individual mandate is, it's a requirement that people either buy health insurance or pay a tax, and the amount of that tax is about 2.5% of your income. So if you make $200,000 a year, or if you make $100,000 a year, rather, it's $2,500. So it's a substantial amount of money. So it is pushing people into the market, whether they want to be in it or not in some situations, and that creates a healthier pool. I can tell you what the Congressional Budget Office says, and then I'll tell you what I think about it. So what the Congressional Budget Office says is that it's going to reduce the number of insured people by about 4 million people this year. Over the course of the next decade, it could reduce it by like up to 13 million people. Now, what I think it may not be taking into account as much is that because the individual mandate has been in effect for 5 years now, is the fact that people now are culturally more attuned to the fact that they have had a requirement for the last 5 years to get health care. So I don't know that the Congressional Budget Office numbers will be as high as they were, and what I will tell you is that my past experience with the Congressional Budget Office was that they listen to economists like me too much, and they say, well, if you don't have a financial incentive to do it, you're not going to do it, and they, so I think that the impact of the loss of the individual mandate is going to be not as dramatic as the Congressional Budget Office says.
Hi, I'm Nancy Seligson. I'm the supervisor of the town of Mamaroneck, and I just wanted to bring it a little closer to home in terms of the effects of the Affordable Care Act in our community. And that is, we're in budget process right now, and last night Jane, Sabrina, and I, with the rest of the town board, heard from our director of the ambulance district that because deductibles are much higher than they used to be, people are not able to pay for their ambulance call, and the insurance companies are paying much less for it. So we, as a town, are getting stuck with some of that bill. So our revenue in our ambulance district has gone down dramatically, and we are then forced to increase our tax levy to pay for ambulance coverage in our community. And I just wanted folks to know that there was a close to home impact of that as well.
You know, I think we've seen through this presentation that this is an issue that we might want to revisit one day down the road. But thank you all for attending. Is there any other housekeeping to be done, Nina?
On behalf of everyone in the summit, thank you so much for coming today. I wish we could have had a much longer breakfast because I still have a lot of questions to ask you, particularly about electronic records, and are we going to be carrying around our records in our cell phones, and you know, all kinds of things like that. But thank you. It was really interesting, and thank you, Larry, for your hard work. The other thing is that our next breakfast is December 11th. And that is our annual meeting where we have the county executive to make a presentation. He'll have his budget, I guess, prepared or in some sort of state. So there's questions about that. There's questions about the tax increase, the basis for it, the airport, all kinds of things. So please come to the breakfast and come equipped to ask a lot of questions. And thank you very much for participating and supporting the summit. Have a good day, everybody.
Thank you to the panel. I want you to know everybody.